Hi there, I'm a PsychNP and I have 11 test questions for you on Bupropion. Ready? Let's learn psych fast. Question 1. Which of the following is a notable side effect profile of Bupropion? A. High risk of intimacy dysfunction. B. Sedation. C. Weight gain. Or D. Modest weight loss. The answer is D. Modest weight loss. Bupropion is known for causing modest weight loss during acute and long-term treatment, which distinguishes it from many other antidepressants that are associated with weight gain. Other side effects are a low risk of intimacy dysfunction, which is why A is incorrect. B, sedation, well, that's also incorrect because the medication causes insomnia. Question 2. Bupropion may be contraindicated in persons with histories of substance abuse due to its association with A. Euphoric feeling, B. Sedation, C. Increased appetite, or D. Hallucinations. Answer A. Euphoric feeling. So bupropion may be associated with a euphoric feeling, so it may be contraindicated in a person with histories of substance abuse. However, because of its dopaminergic effects, bupropion has been explored as a treatment for cocaine cravings. So far, results have been inconclusive, with some patients showing a reduction in drug craving and others finding their craving. Option B, sedation, nope. The medication is associated with a low risk of sedation, so this option is not directly related to the contraindication why a person with history of substance abuse can't take the med. And then C, increased appetite. No, it's actually associated with a modest weight loss rather than increased appetite. So this option also is incorrect. And then the last one, D, hallucination. While bupropion can rarely cause psychotic symptoms such as hallucinations, this is not a primary reason for its contraindication in persons with history of substance abuse disorder. Question 3. What neurotransmitter reuptake does bupropion primarily inhibit? A, serotonin, B, norepinephrine, C, dopamine, or D, GABA? Answer B, norepinephrine. So bupropion does primarily inhibit the reuptake of norepinephrine, which contributes to its antidepressant effects. Question 4. What sexual side effects does bupropion aim to counteract when added to drugs such as an SSRI? Is it A, decreased libido, B, erectile dysfunction, C, decrease intimacy arousal, or D, all of the above? Answer D, all of the above. So this option accurately summarizes the sexual side effects that bupropion aims to counteract, making it a valuable adjunct therapy in individuals experiencing intimacy dysfunction associated with SSRIs. Bupropion may improve intimacy arousal, O completion, and intimacy satisfaction. It is known for its favorable side effect profile in terms of this, making it a valuable adjunct therapy in individuals experiencing associated side effects with SSRI. Question 5. Patients with which condition should not be prescribed bupropion due to potential exacerbation of symptoms? Is it A, major depressive disorder, B, severe anxiety or panic disorder, C, bipolar disorder, or D, obsessive compulsive disorder? Answer B, severe anxiety or panic disorder. This option accurately identifies the condition which bupropion should not be prescribed due to its potential exacerbation of symptoms. Patients with severe anxiety or panic disorders should not be prescribed bupropion. Most likely it's because of its potentiating effects on dopaminergic neurotransmission. Bupropion can cause psychotic symptoms, including hallucinations, delusions, and catatonia, as well as delirium. So let's go over the incorrect answers. A, major depressive disorder? No. Bupropion is commonly prescribed for major depressive disorder and is generally considered safe and effective for this condition. C, bipolar disorder? While bupropion may be less likely to precipitate mania in individuals with bipolar disorder compared to other antidepressants, it's not typically contraindicated for this condition. However, caution should be exercised and it may be used with mood stabilizers in some cases. And then option D, obsessive compulsive disorder. Bupropion is not typically contraindicated for OCD. While it is not the first line of treatment for OCD, it may be used as adjunct therapy in some cases. Question 6. Which population is more likely to have sharp waves on EEG while taking bupropion? Is it A, men, B, children, C, women, or D, the elderly? Answer C, women. So option C is correct. This option accurately identifies the 20% of bupropion population that is more likely to have sharp waves and focal slowing on EEG while taking bupropion. Studies have shown that women are more likely than men to exhibit these EEG abnormalities. The wrong answers. A is wrong because it is more frequently in women than men. B is wrong as the med is not typically given to children. And then D, the elderly, is less accurate. While elderly population may experience EEG abnormalities while taking bupropion, studies suggest that women are more likely to exhibit these abnormalities than an elderly man. Question 7. Which medication should not be used concurrently with bupropion due to possibility of inducing hypertensive crises? Is it A, SSRIs, B, MAOIs, C, antiparkinson's medications, or D, metoprolol? The answer, B, MAOIs. Because of the possibility of inducing hypertensive crisis, bupropion should not be used concurrently with MAOIs. MAOIs can potentiate the effects of bupropion, leading to dangerously high blood pressure. At least 14 days should pass after the discontinuation of an MAOI before initiating treatment with bupropion. All right, let's go over the incorrect answers. A, SSRI. While there may be some potential for interaction between an SSRI and bupropion, it is not typically associated with inducing hypertensive crises. And then C, antiparkinson's medications. While there may be some potential for interaction with these antiparkinson medications with bupropion, they are typically not associated with a hypertensive crisis. And then C, metoprolol, that's that beta blocker commonly used for hypertension and heart rate monitored. While, concurrently with bupropion, it may lead to sinus bradycardia. That is not typically associated, though, with a hypertensive crisis. Question 8. Which medication may rarely cause CNS toxicity, including seizures, when combined with bupropion? Is it A, lithium, B, fluoxetine, C, metoprolol, or D, valproic acid? Answer A, lithium. The combination of bupropion with lithium can increase the risk of CNS toxicity, and that's why it should be used with caution. The wrong answers, let's go over those. B, fluoxetine. While there are some cases of reporting indicating potential adverse effects such as panic, delirium, or seizures with combination of bupropion and fluoxetine, it's not typically associated with a CNS toxicity, including seizures. And then C, metoprolol, that's that beta blocker again, and when used concurrently with bupropion, it may lead to sinus bradycardia, but not CNS toxicity or seizures. And then D, valproic acid is wrong. That's that anticonvulsant medication. And we sometimes use it to treat bipolar disorder. And it can interact with bupropion, but again, not typically associated with CNS toxicity. Question 9. What laboratory interference has been reported with bupropion treatment? A, false positive results on urinary cocaine screens. B, false positive results on urinary benzodiazepine screens. C, false positive results on urinary amphetamine screens. Or D, false positive results on urinary opioid screens. Answer C, false positive results on urinary amphetamine screens. Bupropion has been reported to cause false positive results on urinary amphetamine screens, which can lead to misinterpretation of drug test results. There's no other reports having appeared of laboratory interferences associated with bupropion treatment, so the other options of cocaine, benzodiazepine, and opioids are incorrect. Question 10. How should dosage increase of immediate release bupropion be managed to minimize the risk of seizures? A. Increase should not exceed 100 milligrams in 3 days. B. Increases should not exceed 200 milligrams in 3 days. C. Increases should not exceed 50 milligrams in 3 days. Or D. Increases should not exceed 150 milligrams in 3 days. Answer A. Increases should not exceed 100 milligrams in 3 days. This option accurately describes the recommended approach to managing dosage increases of immediate release bupropion. Because of the risk of seizures, increases in dose should never exceed 100 milligrams in 3 days. A single dose of immediate release bupropion should never exceed 150 milligrams, and the total daily dosage should not exceed 450 milligrams. So option B and D are too high, thus leading to increase the risk of seizures. And then option C is too low, so that would be a subtherapeutic dose. Question 11. How long does treatment for smoking cessation with sustained release bupropion generally last? A. 3 to 6 weeks. B. 7 to 12 weeks. C. 13 to 16 weeks. Or D. 17 to 20 weeks. The answer is B, 7 to 12 weeks. Typically, the duration of treatment for smoking cessation with sustained release bupropion is 7 to 12 weeks. The patient should start taking 150 milligrams a day of sustained release bupropion 10 to 14 days before quitting smoking. On the 4th day, the dosage can be increased to 150 milligrams twice daily. Treatment generally lasts for 7 to 12 weeks to maximize the likelihood of successful smoking cessation. The other options are incorrect, as treatment of only 3 to 6 weeks is more likely to result in a relapse, and longer durations like C and D is not necessary, as most have successfully ceased smoking. Alrighty, all done. If this was helpful for you, give it a like button and share it with a colleague. And don't forget to reward yourself. Click on this next video and learn more about depression.